splenius capitis, and the upper fibers of the trapezius. A blow to this area could also injure these muscles and affect the corresponding movement. Lateral movement is accomplished primarily by the trapezius, splenius capitis, and the sternocleidomastoideus, all working together. Again, a blow to the area listed in point 3 could injure motion here. Rotation of the head could be affected due to injury of the connective tissue that runs from the occipital area of the skull to the axis or second vertebrae in the neck. This includes the membrana tectoria, also known as the occipitoaxial ligament. Also, the alar ligaments could be affected. If this soft tissue is affected, rotation of the head, which occurs primarily between the first and second vertebrae, would be affected by limiting the rotation of the head. There are no discs between any of these segments to be affected. Many of the muscles that attach to the suboccipital area of the skull have been mentioned and include the rectus capitis posterior major, the rectus capitis posterior minor, the obliquus capitis inferior, the obliquus capitis superior, and the nerves that supply these muscles that could be injured in the process include the dorsal ramus of the suboccipital nerve and the dorsal primary division of the suboccipital nerve. The suboccipital nerve, through its connections in the obliquus inferior muscle, joins with the dorsal division of the second cervical nerve. The second cervical nerve also has connections with the occipital artery. The suboccipital nerve, also known as the first cervical nerve, connects medially to the vertebral artery. The vertebral artery goes through the foramen magnum inside the skull to form a part of the basilar artery. Therefore, a blow to point number 3 could also cause death from bleeding due to rupture of this artery. Needless to say that a blow to this area, because of the ligamentaceous damage mentioned earlier, would cause dislocation of the skull on the first vertebrae or the first vertebrae on the second vertebrae and cause cord compression and immediate death. This would require a fairly strong blow. Rupturing the blood vessel may not require as strong a blow, however. Of course, any hard contact to the brain, which is the central part of the nervous system itself, could cause immediate death through lacerations of brain tissue. There are occipital lymph nodes that range from 1 to 3 in number on the back of the head that drain the occipital region of the scalp. However, blows to these, although they could cause injury to a person, would not result in immediate death. Point number 4 is located at the temple, which will cause death at any time. In this area, there are no major lymph nodes. However, there are many chains of lymph channels that drain into the parotid lymph nodes and the posterior auricular lymph nodes that may be damaged upon impact. Branches of the maxillary artery, which includes the posterior deep temporal artery and the anterior deep temporal artery, as well as the superficial temporal artery, could be injured upon impact. The deep temporal artery, the anterior deep temporal artery, the superficial temporal artery, and the posterior temporal artery probably would not result in immediate death. However, related to these, through the maxillary artery, is the middle meningeal artery. It is the largest and most constant of the arteries which supply the dura mater. This rupture here could very likely result in immediate death. The superficial veins that could be injured upon blow to the temporal area would include the transverse facial vein, the middle temporal vein, and the superior temporal vein. Of course, direct injury to the brain itself could result in immediate death and unconsciousness. Point number 5 is struck at 8:30 a.m. It is supposed to cause illness and death in a week or so. The area struck is to the left of the sternum at approximately the level of the second rib, which is at the junction between the manubrium and the sternum. This is approximately 3 finger widths below the insertion of the clavicle, collarbone on the sternum. The muscle of this area is the pectoralis major. The main nerve to that is the pectoral nerves. There are two of these nerves, one lateral and one medial. The medial and lateral pectoral nerves contain fibers from the 5th, 6th, 7th, and 8th cervical, and also the first thoracic nerve. The glands and organs that may receive innervation from the 7th and 8th cervical nerve, as well as the first thoracic nerve, include the thyroid gland, the lungs, and the heart. It is possible that because of dual innervation, the heart and lungs and thyroid gland could suffer damage due to a reciprocal nerve reflex and suffer slow damage. Such damage could possibly result in tissue deterioration. The arteries that may be affected from such a strike could include the pectoral branches of the axillary artery. This would be at the superficial level. A little deeper, the perforating branches of the internal thoracic artery could be affected from a slightly heavier blow. With a deep, hard blow, the subclavian artery may be affected. The vein that could be affected in this area with deep penetration would be the left brachiocephalic vein. The lymph nodes that could be affected on the superficial level would be the sternal nodes. Deeper vessels that could be affected would include the lymphatic vessels of the heart, the lymphatic vessels of the lungs, and the lymphatic vessels of the pleura. Point 6 occurs at 6 a.m. and can be on the left or right side and cause paralysis or illness. It is at the juncture of the 7th and 8th rib on the front of the body. The 11th and 12th ribs are floating ribs. The 10th rib is partially attached, so this appears to be between the 7th and 9th rib, the last couple of attached ribs. The muscles in this area would be the attachments of the transversus abdominis, the internal intercostalis between the ribs, the obliquus externus, and the end attachments of the serratus anterior. The connective fascia, known as the linea semilunarius, could be affected here also. The nerves affected would be the 8th to 12th intercostal, the iliohypogastric, the ilioguinal nerves, and also the intercostal nerves, if the blow was between the ribs. Superficial arteries that could be affected would include the musculophrenic artery, which is a branch of the internal thoracic artery. The vein in this area that could be affected would be primarily anterior intercostal vein, which is a branch of the internal thoracic vein. A deep blow on the right could affect the hepatic blood vessels. Lymph nodes in this area that could be affected from such a blow would be the intercostal nodes and vessels. The internal organs that could be affected on the right include the hepatic flexure of the large intestine, and on the left, the splenic flexure of the large intestine. Other organs that could be affected include the pyloric vestibule of the greater curvature of the stomach on the left. On the right, the primary organ that also may be affected would be the caudal or the inferior portion of the liver. This could affect the elimination via the large intestine. It could affect digestion and the transformation of energy on the left via interference with the stomach. It could influence the enzymatic functions of the body by interfering with the liver on the right. Point number 7 occurs at 6:30 a.m. and will cause illness in about a year, or delay in 1 year. Illness delay in 1 year. The area appears just proximal to the acromioclavicular joint, which is up from the shoulder towards the neck, just into the soft depression. A hard downward blow could affect the acromioclavicular joint, the coracoclavicular joint, or the coracoacromial joint. The ligaments that could be affected would be the coracoclavicular ligament, which consists of two separate ligaments, the trapezoid and the conoid ligaments. A hard downward blow could affect the subscapularis bursa. The muscles that could be potentially affected would be the trapezius, where it attaches to the acromion and the spine of the scapula. Also, the omohyoid muscle could be injured as it passes underneath the trapezius. The nerve innervating the trapezius muscle is the spinal accessory nerve, which is a spinal part of the 11th cranial nerve and branches from the 3rd and 4th cervical nerves. The trapezius originates at the EOP, the external occipital protuberance, and has originating attachments from the spinous processes of the 7th cervical vertebrae and the spinous processes of all the thoracic vertebrae. It then proceeds down and laterally from the upper attachments. It also proceeds up and laterally from the lower attachments. It travels from the middle attachments straight across and then inserts on the posterior portion of the outside of the clavicle, collarbone. Middle fibers insert into the upper lip of the spine in the scapula. The lowest fibers meet near the scapula and then end on the inner end of the scapular spine, inserting on the tubercle at the apex of this surface. Injuring the trapezius can interfere with the proper motion of the shoulder in regards to the rotation of the shoulder blade and raising the shoulder and in pulling the shoulder blade back towards the spinal column. The omohyoid muscle is innervated by branches of fibers that arise from the first 3 cervical nerves. The muscle draws the larynx and hyoid bone in the throat area downward. Injuring the omohyoid could affect the abilities of swallowing and breathing in, or inspiration. Moderate percussion to this area could injure the transverse cervical artery. A very hard, deep concussion here could injure the transverse scapular artery and the thoracoacromial artery. The major vein that could be injured in this area is the transverse cervical vein. Deep concussion here could also injure the brachial plexus as it comes out of the neck and enters into the arm. The brachial plexus is a deep major bundle of nerve fibers. The brachial plexus controls most of the major functioning of the upper arm. The lymph vessels in the area that could be injured would be the supraclavicular nodes. Point number 8 is struck at 7 a.m. and will cause illness, tiredness, and death within 4 months. With this point, the trapezius will again be the major muscle affected. The omohyoid would not be affected in this case. The same lymph nodes, nerves, arteries, and veins would be affected by mild to moderate blows as mentioned above for point number 7. Point number 9 occurs at 10 a.m. and is on the back. It is located to the inside portion of the lower third of the shoulder blade. It is 1.5 inches to the inside of the shoulder blade and 1.5 inches to 2 inches from the spine. It is on the right side of the body and is supposed to result in illness, increased fever within 3 weeks, and will ultimately be fatal. The deep muscles affected primarily would be the iliocostalis dorsi and the longissimus dorsi. The nerves innervating the longissimus dorsi are branches of the dorsal primary divisions of the spinal nerves. Its action is to extend the vertebral column and bend it to one side and draw the ribs downward. The innervation of the iliocostalis is branches of the dorsal primary divisions of the spinal nerves. Its action is to extend the vertebral column and bend it to one side and draw the ribs downward. Primarily, this point lies over the lungs, and a deep blow here would penetrate into the lungs. Point number 10 occurs at 3 p.m. with the results of paralyzing the legs within 6 months. This appears to be the right of approximately the second and third lumbar vertebrae. Even though there are many different muscles that could be affected, the primary muscles that would be affected from a blow to this area would be the multifidus and the erector spinae, primarily the longissimus dorsi portion. The nerves that would be affected from striking the longissimus dorsi would be the dorsal primary divisions of the associated spinal nerves. The action of these muscles is to extend the vertebral columns. In the case of the longissimus, there is also the action of bending the spine to one side. If a blockage in these muscles were to occur, it could affect extension of the legs, resulting in partial loss of movement. The multifidus muscle, with the nerve innervations of the dorsal primary division of the spinal nerves, also extends the vertebral column and rotates it toward the opposite side. Injury to this would also affect the movement of the upper thigh, restricting its motion. The veins that would be affected in this case would be the external vertebral venous plexuses, aka extraspinal veins. However, they are not as developed in the lumbar spine as in the cervical spine. Affecting the spinal nerves in this area could cause interference with nerves from the spine that control the appendix, abdomen, the upper leg, sexual organs, bladder, and the knees, just to name a few. The spinal nerves from the second and third lumbar vertebrae exit the spine, parts of which combine into the lumbar splanchnic nerve, and from there enter the inferior mesenteric ganglion. From there, fibers innervate the large intestine, rectum, sexual organs, kidneys, and the bladder. Interference with these nerves through a blow to this area is likely. There is a method of acupuncture known as Hua-to Jia-ji, in which the internal viscera are stimulated by the insertion of acupuncture needles along the spine, paraspinally. For example, if one was having lung problems, they would use needles along the sides of the vertebrae in the area between the shoulder blades. If one was having bladder problems, they'd use needles to the sides of the vertebrae in the middle of the lower back. If there was intention behind the movement of qi from a hand strike, it is not entirely unlikely that one could affect the internal organs, the muscles to the legs, etc., in a method similar to Hua-to Jia-ji, except with an entirely different result. Point number 11 is set to occur at 2 p.m., causing a malfunction of the spine and the central nervous system. It is to the left of the spine between the area of the 9th and 11th thoracic vertebrae, approximately 2.5 inches to 3 inches to the side from the spine. In this area, sections of the nerves from the 9th through 11th thoracic vertebra exit from the spine via the lesser